For a long, long time at JDRF, for the first 30, 40 years of our existence, if there was ever an extra penny available, it was going to the research. And that's really, if you have spent time with JDRF's International Board, who are volunteers just like all of you, this has been a healthy conversation that's happened on a regular basis. Should we spend money on, or should we be pouring more dollars towards the research, recognizing how big a task we have ahead of us and how much work there is to be done? And when push has always come to shove, JDRF has always spent that money and sent it towards the research and not towards marketing and this kind of material. That said, we need to raise more money than we've ever raised before. JDRF is at a whole new place in terms of what we've made happen in the past few decades and where we are now. In fact, I'm going to talk about it this evening. And to raise that money, awareness is vital, and having more people become engaged and more people deciding to support the organization is really important, and this is where marketing becomes important. So there's sort of a healthy balance, and a piece of that has now emerged, that we have a new set of videos and materials, print materials, a whole integrated suite of things that were produced this past summer, and this is one of the videos that came out of that. And so we just really wanted to share that with folks and kind of let you get to see it, and that you know that those are aware, that they are out there. You can also see them on the JDRF YouTube site. And there's a whole host of them. This is just one of them, and we're going to show one more at the end. But just to give you a sense that JDRF has these conversations, and we recognize the need to do some of these things, but to give you some of the understanding of what the balancing act is. So as I get started, I'm Tom Brobson. It's great to be back here. The last time I was here, I was going low while I spoke, and there were a bunch of moms in the room that kept trying to feed me emergency sugar rations, glucose tabs, and so I actually ate my dinner beforehand, and my blood sugars are going up right now, so I'm not going to do that again. Learned my lesson. So I do have type 1 diabetes, but I don't have any MD or PhD kind of initials. I'm not a scientist, I'm not a doctor. I do spend a lot of time with that community and a lot of time with our JDRF research staff that help to manage JDRF's global research portfolio. And then I always say I have the best job in the world because I get to hang out with some of the brightest people you could ever hope to meet that are managing JDRF's research and driving the advances that we see going on in laboratories all over the world. And then I get to come and share what I've learned with you guys. And so to me, as a type 1, I just find that incredibly powerful job to be able to say I have, that my job is, in some regards, to give shareholder report, is to come and let you know that all the money that you've been raising is driving actual activity and results, and give you a sense of what the horizon looks like, what's exciting, and what we see happening when, and so on and so forth. So that's what we're going to do a little bit of this evening. I have way more slides than we're going to cover. So I'll tell you another thing about myself. Well, I also perhaps secure this wire so I don't make noises the whole evening. I don't like PowerPoint. So if you've heard me talk before, you know that I talk about a belief in death by PowerPoint. I one time saw the Lincoln's Gettysburg Address turned into a PowerPoint. And you realize something vital is lost, and that's not me. Now he's giving me the okay. Okay. So I have some PowerPoint slides, and they're going to be up here on the screen, but they're meant to help guide us and kind of take us through some key points. But I'm way more interested, particularly because we turned out to be in this great setting and this nice group, to have a conversation. So I like to get questions. Questions mean I'm going where you guys want to go, and we're exploring the things that you guys want to explore, as opposed to me just kind of standing up here and blathering on. So can I get agreement that people will ask me questions? I know I have a couple of people right up front that are going to ask me some questions. So hopefully I'll give you guys some good information, some things that are interesting and prompt questions. But please do ask them, really, because it's much more interesting to go where you guys want to go, as opposed to me just kind of giving you what I think is important. So, well, actually, before I even go there, I want to go back one slide to the beginning here. A plan for a world without type 1 diabetes. And again, this is something Tom and I were discussing about at the beginning. The word plan is really vital here. You know, you have to have a comprehensive strategy. JDRF has had a strategy and has been implementing against it. year after year after year, decade after decade after decade, and we don't always do a good job of explaining that, and we don't always make it clear that we have a plan for getting where we're going. So part of what I'm going to do this evening is kind of weave together some of the themes and threads of what that plan looks like and where some of the specific research advances are against that framework. So a plan for a world without type 1 diabetes. And that's where we start this, JDRF's vision. So vision statements, oops, and I'm jumping too far ahead. Vision statements are the easiest ones to make, right? Vision statements are saying, JFK saying, we're going to put an American on the moon in this next decade, right? 10 years. And that's a powerful thing to say, and in some ways a really easy thing to say, right? He just had to stand up there in front of a bunch of people and say, we're going to do this. The people who were sweating bullets at that very moment were all the engineers all around the country going, oh my gosh, we have no idea how we are going to put a man, we never even put a man into orbit yet, but we're going to put a man into orbit and we're going to send him all the way to the moon and land him and bring him back safely, right? That's the mission. So the vision is the big statement, what you're going to accomplish, the big thing you want to do. And then mission is how you actually are going to go about making that happen, right? How you actually get the person into orbit, send them to the moon, land them, pick them back up and bring them home. So JDRF's vision statement is pretty straightforward, and this is about as simple an image as you could hope to come up with. I like big images and not many words. So a world without type 1 diabetes. That's what JDRF is striving to create. Now that's a pretty impressive undertaking if you really sort of step back and drill down into, well, what does that vision mean? So if you've heard me speak before, you know I'll talk about that. Means we want to take a person. I was in Syracuse, New York this past June, and there was a gentleman there who is in his 90s, is the known to be longest living person with type 1 diabetes, has been living with type 1 for more than 80 years. We would like to cure that person. We would like to cure the 53-year-old who's been living with this for 10 years. We'd like to be curing the person who's 5 years away from being diagnosed. They're walking around with a big target on their back and they don't know it, but they are going to get type 1 diabetes. We want to cure all those people, right? This is not a small thing that we're undertaking to do. Again, easy to say that we want to create a world without type 1 diabetes, but exactly what does that look like and what is a cure for all those different kinds of people? What a cure looks like for a person who's 5 years away from ever being diagnosed versus a person who's been living with it for 20 years? Very different things. And yet JDRF covers all of that. And I will touch on these things. We'll get more and more, we'll drill down as we sort of go into these slides. Any questions? But you promised you would ask questions. You're having wine, you're having a beer, you can ask questions. Okay, I will start calling on people. So, vision, easy thing to say. The big vision is creating a world without type 1 diabetes, but so how do you get there? What's the mission statement? How do you actually create that world? And so the phrase that JDRF has been using a lot recently is less until none. And less until none, what does that mean? We want to see sort of a continuous cascade of life-changing therapies reaching all of us affected by this disease, and see those therapies step by step remove the burden of this disease and lessen its impact in our lives, until finally we look back one day and realize it's gone, that we don't have type 1, that we've actually created this world without type 1 diabetes. And that's not me, because I'm not moving. I'm not getting the okay this time. Now I'm getting the okay. So, see, they should have let me just use my own voice. So, less until none. Less, and so literally less burden, less invasive, less complex, and less dangerous, right? We want to see each of these therapies come to us and step by step move us forward in this sort of progression. And I'm going to talk to you exactly what that looks like in granular detail here in just a sec. So fundamentally, less than until none. And very simple way of characterizing things. And I think it'll make sense to you by the time I get to the end where I've walked you through some of the very specific examples we're going to look at this evening, what we mean by less until none. So all of that then drives us to where we say less type 1 becomes type none. I was in a chapter and there was a guy who was selling ends, because that's all it takes is the end to create to turn type 1 into type none. I thought it was a pretty interesting thing. So he's asking people if they wanted to buy an N. So this is where JDRF is going with this whole video campaign, trying to drive type 1 to type none. I think we all understand this, right? Get to a world without type 1 diabetes. And why is that necessary, right? I said we want to have less until none. We want to make it less burdensome, less complex, less dangerous, right? Living with type 1 is a constant balancing act. And I don't always use this example, but I used it. I was actually in Little Rock, Arkansas last week, and I used it, and the folks there were like, man, I love that analogy. And I don't think it's me, is it? So maybe it is me. So less until none. Or no, I'm not saying less until none. So I want to use this analogy for life as a balancing act. Or a lot of different ways that people have for completing the sentence, having type 1 is like, right? Is like what? And for me, I always say having type 1 diabetes is like, it's like I'm out on the interstate, cruising along at 70 miles an hour with lots of oncoming lanes of traffic, and I'm told I need to take a left-hand turn against all those lanes of oncoming traffic, and I need to start making that turn 45 minutes before I get to it. Right? Because that's how long it takes insulin to come on board and start doing what it's supposed to do. I ate dinner, but I bolused right as dinner was starting, so now my insulin is trying to catch up with what I was doing there with what I was eating. So I'm going to make a left-hand turn against traffic, crossing 6 lanes of traffic oncoming, and I have to start making the turn 45 minutes before I ever get to it. And if I overshoot or undershoot, I'm in a bad place that every type 1 goes there pretty much every day. Right? We go too high, we go too low, and we know if we go way too high, really bad things happen. If we go way too low, really bad things happen. So making this left-hand turn 45 minutes before I get to it, and oh yeah, I'm blindfolded for most of it. Right? Because except for when I do finger sticks, I don't really know exactly where I am. I don't know exactly where my blood sugar is every single moment of every single day. I can't keep track of it. I wear a CGM, and in a second I'll pull it out and we'll find out how far my blood sugars have gone up based on dinner. But I still can't be staring at it all day long. So I can get little points of time information to help me make this left-hand turn 45 minutes before I get to it against all those lanes of traffic. And then finally, I don't know whether I'm driving a sports car or an old jalopy. I don't know whether I had a great night's sleep and lots of good exercise and my body is performing exactly the way I like it to, right? Or I had a bad night's sleep and I've been traveling a lot and my body is acting like an old heap and it does not want to perform the way I think it should. So the exact same meal and the exact same insulin can give me a completely different result than what I was expecting or would normally expect, right? That's complex. That's a lot of difficult stuff that I, as an adult, have to manage every single minute, every single day, all day long, and we ask little kids to do it the same way. There's nothing easy about living with type 1 diabetes. It's a complex disease. So there is a lot here of less until none. There's a lot of ways that we can lessen the impact of type 1 in our lives and improve everybody's quality of life and step by step move closer to creating this world without type 1 diabetes. So again, what do I mean? We're going to start to drill down deeper. So JDRF talks about working the pipeline. Again, this is speaking to the plan. And again, any questions? Because I'm happy to take questions. Everyone's being very quiet. So you got to work the pipeline. So the pipeline literally starts at the left with basic discovery research. This is our classic work that we do at University of Wisconsin or lots of other universities all around the globe. We truly are global. There's some $530 million under active management at this very moment by JDRF, and it spans the globe. Like 27, 28 different countries, right? This is a lot of work that we have underway, covering a whole lot of areas. This is the kind of basic discovery research where we're asking really important questions and hopefully finding out really, really good answers. From the laboratory, we need to step into clinical development. So Jamie mentioned me doing artificial pancreas trials and other clinical trials. So this is the actual step of leaving the laboratory behind and leaving, I always say, mice behind and going into human beings, right? We need to start testing things in people. So we have to be funding and supporting clinical development work, clinical research, clinical trials. JDRF has a large number of human clinical trials underway because we've been working this pipeline segment by segment. Right in tandem with that, as you start to move out of the laboratory and into testing into human beings, you also need to be comprehensively working with the regulatory environment. We have to have the FDA working with us so we understand what the regulatory environment looks like, what it means to do the first safety test in a human being of something that's never been done in a human being before, what it looks like to get to advanced trials so something can be approved for commercialization and sold to us as patients, right? That's what we work with the FDA for. Again, earlier we were talking and somebody was saying FDA, and I was saying, you know, actually FDA is a great friend to us, and we work closely with the FDA. How many people in this room are grassroots advocates for JDRF? I got 1, 2, 3, 4, come on, every hand should go up, right? Being a grassroots advocate is incredibly important. It's how all of us as type 1s get our voices heard in DC. It's how we make sure Congress renews the special diabetes program that helps to match the money that we raise every year, $150 million that matches the money that we raise every year to support type 1 research. It's how we get the FDA to pay attention to things so we can kind of pound on their desk and say, you're not paying enough attention here. You're taking too long to make something happen. And so the reason why I asked this question at this very moment was JDRF really felt like the FDA was not doing some of the things we were hoping to see or not moving as fast as we were hoping to see in the regulatory landscape for the artificial pancreas. So we convened a group of expertise and we helped to bring that case then to the FDA saying, here's where we think you should go. But we used all of the grassroots advocates and your voices to help keep the pressure on the FDA to recognize that there was a type 1 community that desperately wanted things to be improved. And as a result, that whole world has changed. We have a whole new team of people helping to manage this at FDA. They turn things around on a dime for us. They are our pals. We gave an award to the head of the FDA. I was just reading today that the FDA has approved 39 new drugs for use in the United States since the beginning of this calendar year, and that's more new drugs approved than in the previous 15 years. So we're seeing the FDA is going to a whole new place in terms of working with patients and moving things faster through the regulatory environment. And that's part of working the pipeline. Finally, we also have to work with the reimbursement community. We have to work with the insurers to make sure that as these therapies are developed, they're going to be available, that we can afford them. Anybody who's aware of JDRF's work with the continuous glucose monitor knows what we do there. That this is CGM is probably, I can pull it out of my pocket right now. So CGM, and find out I'm at 184. Wow. So that's my little bit of dinner. So this is the equivalent of pricking my finger several hundred times a day, only I didn't have to. I was able to just reach into my pocket and push a little button and see approximately where my blood sugars are, 184 and starting to go steady. So that's post-dinner, that's pretty good. This is probably one of the biggest advances in the treatment of type 1 diabetes in the last 20 years, and when it first came out, it was not reimbursed by insurance. And JDRF really felt that was a problem. We basically went to the insurance industry and said, what do you need? Why are you not covering this? This is going to obviously improve the type 1's ability to make that left-hand turn 45 minutes in advance. We're going to be able to have a little bit less of a blindfold on, really help us get our blood sugars into a better place. And the insurance industry said, we need more data that conclusively demonstrates that wearing CGM will result in an improved A1C. And if you can show us that, we'll start covering it. So JDRF launched it's called a phase 4 trial, a post, it's already been released for consumers to buy, but we launched a big trial of hundreds of people wearing CGM for 6 months or more to conclusively demonstrate that wearing CGM would result in an improved A1C. And we concluded that trial, the data's unlocked, was crunched, and immediately saw that that was in fact true, that people's A1Cs dropped if they wore CGM. And so we went to the insurance industry and said, you wanted more data? Here it is. And then we saw the insurance industry change its entire format and say, okay, CGM is something we will now look at covering. And so now where I used to travel the country and it was very hard for people to be obtaining CGM, now pretty much anywhere I go, people are able to get access to it. So this is another part of what JDRF is doing. Remember, we're working this pipeline, so from soup to nuts, right? From basic discovery research in the lab all the way to reimbursement, that's what we're doing. But none of it matters if it doesn't deliver and reach patients. Success is reaching patients. For JDRF, success means something has gotten to the patient and is available that changes that person's experience of type 1 diabetes. So the big word for all of this is translational research, right? Taking everything from the lab, from a basic new idea that seems to have promise, and putting it into a human being and testing it and then getting it commercially available and having it available commercially is translation. It's translating that idea and turning it into something in humans. My favorite way of doing this, if you've heard me talk before, is the simplest way to understand this is how many people have read about something that's cured type 1 diabetes in mice, right? Every hand goes up. And how many of us are really tired of reading about healthy mice, right? Mice, but not that much, right? What this is all about is healthy human beings. We want to see these therapies reaching human beings. And to do that, we need to be actively translating. If there's one big word to walk away from, it's translation and translational work, and that JDRF is working hard to sort of accelerate that translational environment. And the good news is we've got a lot to translate. There's a lot that we've done. The previous 30 years of investments have driven some significant advances, and we're now actively taking those new discoveries that were made in mice and laboratories and figuring out how to get some of them, at least, to work in human beings. Because on some really important level, we are ever so slightly different than mice, right? We are definitely, there's some people I meet, I'm not so sure, but most of us are different than mice. So we really need to get these things into human beings. Again, does this all make sense? This is all big picture stuff. Happy to answer questions.
So with the change of the FDA, does that have any impact on the costs of going through the pipeline? I've heard some numbers before that were pretty intimidating in terms of the cost to get something through the various trial phases of the FDA.
So everybody hear that question. The question is, does things moving more rapidly through FDA, does that change the cost environment of how much it costs to move things through the pipeline? And the answer is, on some level, yes. I mean, every time you take longer to move something through, you've got all those people sitting around waiting to do something, or all those things teed up ready to go, and it isn't going, that's costing you money, right? So the more efficient that can be, the less money needs to be spent. The better understood we are on what the roadmap looks like for making our way through this environment, the more efficient the companies and we can be in making sure we follow the roadmap. So understanding what the regulatory environment looks like is really important, and that it's highly responsive is really important. It's still incredibly expensive, right? So the number that's frequently out there is to move something from a basic idea in a laboratory with a scientist all the way through to a new product that's available to patients is estimated to cost $1 billion or more, right? And that's over, say, 20 years. That's an expensive, big number. JDRF has already driven more than $1 billion of money towards research, right? This gives you just a small sense of why we need to be growing this, and I'm going to get to this in spades here in just a sec. So the two areas then, research and advocacy, have to work together. Advocacy is the grassroots advocates piece that I was saying earlier, and research is what keeps driving this through. To push things through the pipeline, we have to be working all of the segments of this and pouring money into this. If you ever wonder why we're raising more money all the time, it's because it costs money to make this system work. So let's jump into something very concrete that will hopefully drive home some of these pieces around the idea of less until none and translational work and all those things that I've been talking about. So artificial pancreas. And now I have to see where I have things in my pockets. Okay, so artificial pancreas is three things, and I've got too many devices on my body right now. I've got the transmitter in my pocket. Okay, so three things. So one thing we're very familiar with. This is, I was going in to get, this is my insulin pump, right? It can be any kind of an insulin pump. I just happen to wear the Insulet Omnipod pump, that's what this is. But it's an insulin pump, right? How many people in this room well, how many people do I have in this room that are type 1? Good number. And how many people are wearing pumps? A good number, right? So there's lots of different kinds of pumps, but this is technology that we're familiar with. And we understand that pumps, they have their downside, right? It's a piece of technology, but they have their upside. They give us back a lot more control and tend to deliver improved control, right? And it's a technology that we're very familiar with. So one part of the artificial pancreas then is an insulin pump. Another is this device that I was showing earlier, which is a continuous glucose monitor, or CGM, and now I'm at 186 and gone flat, so I've definitely plateaued. Not too bad. Again, so this is a little device that I have here on the back of my arm. It's a little wireless device that's pushing out a signal to my little receiver, right? This is instead of pricking my finger several hundred times, I don't have to. This is just telling me. It alarms if I'm going high. It alarms if I'm going low, right? And helps to start improving my ability to find my way through that 45-minute turn that I was talking about earlier. This is technology that JDRF played a role in. And obviously, as I was talking about with our work with the reimbursement and the insurers, we really wanted to see this become widely available. It's still underutilized. You know, how many people in this room wear CGM? Good number. That's good. We want to see everybody getting access to this and using this because this is where the future is. Having this information is a big important part of what becomes artificial pancreas technology. So what we really want to do then in an artificial pancreas is put the pump and the sensor together. We want to take the real-time data feed from the sensor and push it into a computer program that can make decisions and give instructions to the pump automatically and start to automate all of the complexities that I was talking about in making that 45-minute turn. I was saying how I have to be blindfolded most of the time because I can't stare at this every 2 seconds to see where my blood sugar is. But that is something that a computer program can do, right? Technology can be turned on, and it can monitor us all the time when we're paying attention or not. It can be paying attention. This is something that technology is good at. So the piece that's always been missing then was that technology, was the computer program that would allow these two things to work together. So JDRF decided that it was going to really decide to put some money into this as a way of seeing whether it was possible. And we really began that in 2005. The first big allocation of funds came in 2006. It was only $4 million. It's a very small outlay for JDRF in terms of our total portfolio. And basically what we were doing with that $4 million was, what we had seen was that with the advent of wireless devices, so the pump that I wear takes wireless control, the Animus Ping takes wireless control, that we are seeing this ability to use wireless communications to integrate these technologies and allow them to start working together in a way that we'd never seen before. So as we came into 2005, really began to realize that maybe for the first time we were at a place where we could start to look at bringing all these pieces together to see if we could help to automate the delivery of insulin and the management of type 1 diabetes. And now it says I've lost signal. We're just not having a good evening. There we go, comes back. All right, so the computer went to sleep. So 2005, we started to put money. 2006 was actually when we allocated the cash. And what we did then was go over that first segment I was talking about, classic, into the laboratory, working with researchers, asking the question, can we close this loop? Can we project an hour into the future, 45 minutes into the future, where we think a person's blood sugars are going to go? And if yes, can we then give instructions to the pump to successfully help to start automating these systems? That was the question. And the great news was that by 2007, the answer pretty much had arrived, yes. But JDRF always asks itself basic questions. Is this stuff important? Is this stuff really important? So is an artificial pancreas important? This is one way of trying to get at this. I talked about making that left-hand turn and overshooting and undershooting, and everyone with type 1 in this room knows how often we overshoot and undershoot. Right now I'm at 186. That's too high. 140 is supposed to be the upper limit. I've gone beyond where I was supposed to for that turn. So this is not easy to do. If we put CGMs on lots of people and we take their data, we've discovered that they spend 41% of their time out of bounds, too high or too low. And this is in people who are wearing CGM who tend to be better controlled. 41% of their day, too high and too low. And this isn't a good group. And that's a lousy number. This is where all the bad things come from. This is where the complications come from. This is where DKA comes from. This is where those scary lows where you need to be rescued with glucagon come from, right? We need to shrink this time out of range as much as we possibly can. There's another interesting group of type 1s in something called the T1D exchange. In fact, JDRF just announced a big round of funding to that group. And it's 26,000 type 1s who are allowing their data to be tracked and followed all the time. And what we're finding is that after people are sort of reach teenage years, fewer than 70% of us, well, fewer than 30% of us, more than 70% of us, do not meet our A1C target. In fact, the average A1C target for people in the T1D exchange is over 8. That's a crummy number, right? our target A1C is 6.8. That's where we're all supposed to be. Keep these numbers in mind because I'm going to show you some really specific things here in a second. 6.8 is where we're supposed to be. Very few of us are getting to that. And 6.8 isn't all that good a number either, right? If you have high blood pressure, your doctor says you need to get to 120 over 80. They don't say, get within 150% of 120 over 80. But because having an A1C that's close to normal puts you so at risk for going badly low, our doctors tell us, you're not going to be able to get to the normal range, 4.5 to 5.2. You really need to just shoot for 6.8. Get close enough. It's not as good as it should be, but it's the good balance between going too low too often and being where we're in a safe place. So these are bad numbers, and artificial pancreas takes square aim at those things. And I think in a second you'll be able to see exactly how it achieves that. So I told you 2006 we did our first outlay of money. By 2008, I was actually able to sit in the hospital and be a guinea pig. I became that translational activity. Okay, let's get things out of the laboratory and put it into human beings. So I was one of the first human beings to get to sit in the hospital and test artificial pancreas technology, and that's a picture of me doing it. So when I was here in 2010, I got to talk about some of this, and you're going to be able to see very graphically here how things have jumped forward. So 2008, this is me in the hospital, and I actually have a smile on my face, and I'm kind of happy because I'm getting to eat and live on an artificial pancreas. Literally, my dinner came, and they said, go ahead and eat. I didn't have to pull out my pump and dial up insulin. I didn't have to do anything special. I just ate my meal. And this new software, completely newfangled thing, had never been used before, took over and was managing my blood sugars. And I remember what it was like very clearly. I mean, there was lots of moments of like, ooh, I wonder if it's, how's it doing, right? Constantly looking to see whether it was doing its job and doing it well. And then watching as it did. It was very cool to see. That's the very act of translation, that very first step out of the laboratory into, it's definitely not me. I don't think, is it? Sorry, guys. That big step out of, I don't think it's me, but it might be me. I don't see how it could be me. Anyway, I told you I shouldn't have used a microphone. So, big step. So notice in this picture that I've got some wires running out of a fanny pack at my waist. And by the way, it was about 5 degrees. It does get cold in Virginia, maybe not as cold as Madison, Wisconsin as often. But it was about 5 degrees. It was January. I had an IV in each arm. They were drawing blood every 5 minutes. I had to keep my body as warm as possible to keep those veins open so they would flow. They couldn't use the blood, the anti-clotting agent that they normally use because it was potentially interfere with what they were trying to do. So it was, that's why I have all the clothing on, trying to be warm, as warm can be. And, but you see those wires running from that fanny pack, those are attached to 2 laptops that are on a cart with wheels, right? So that software I'd been talking about, it existed and it was working and it was on laptop computers. I was wearing 2 pumps and 2 sensors and an IV in each arm. I felt like I was sort of Radio Free Europe, right? You could tune me into lots of things. And yet I was really excited and pumped up because it worked, right? The computer programs were running in laptop computers, but they worked. They were able to significantly automate the delivery of my insulin and keep me in a really good place. And I was pretty excited. Never mind if somebody had said to me, well, how are you going to walk around with a laptop computer all the time? I was like, I don't really know, but we'll figure that out, right? First, you just have to make that leap of faith out of the laboratory and the idea and try it for the first time in human beings, and we had done that, and it worked. But this wasn't much fun, right? Having blood drawn out of your arms, being in the hospital, this is a safety trial, so you're really trying to make sure this is safe, being attached to laptops. They fed me for 24 hours. I had my meals, and then certain things happen at a certain time afterwards, and you have to go down the hall to use the bathroom, and imagine everybody having to come with you with a little cart on wheels with your laptops and your wires to make sure you don't come unplugged. It was not exactly a fun time, right? I couldn't take a shower. It was not much fun. And yet I was incredibly over the moon excited about it, right? Because I didn't have to think about my diabetes for a while. I actually got to let something take over and help me make that left-hand turn 45 minutes before I got to them each time. And to me, it was an awesome experience. So that's what it was like in 2008. And right out of the shot, right out of the gate, the system did significantly better in managing than I had done, right? So between 9:30 at night and 8 in the morning, it kept me essentially steady. It used 48% less insulin in the overnight. That was huge. That's a lot less insulin. Turns out when you're not bouncing around all over the place, you don't need as much insulin. Once you get to a steady state, it's easier to stay there and you need less insulin. That's really cool. It shut off my basals for about 4 hours in the overnight to prevent me from going low. So it saw that I had a chance of going low, and it actually pulled back and turned off the insulin and prevented me from going low, and then it kicked back on again as my blood sugar started to rise for the dawn phenomenon. Each time you go in to do one of these trials, you go in and there's a period where you're running the show, right? You do everything on a big clock. So you eat your meals at the exact same time, and it's the exact same meal weighed out to the last gram. And then you come back and you do it again, only that time the artificial pancreas takes over and it runs the show. And so when I ran the show in my first 24 hours, I went low 6 times. The system took over, it went low once in 24 hours. That was a huge improvement in my eyes. I went high once in 24 hours, it went high once in 24 hours, and those numbers were pretty comparable, only about 20-point difference, right? So here's the very first time ever tested in human beings, and the system's already doing significantly better than I can do for myself, and I'm a fairly tightly controlled type 1. Remember I was talking about that shrinking time out of range? When I ran the show, I spent more than 4 hours too high or too low, and in my case, mostly too low. When the system took over and ran me, it took that and shrank it to less than 1 hour, right? This is the very first giant dinosaur version of artificial pancreas. There's now an artificial pancreas museum at the University of Virginia. And I should explain, I get to do these trials because my endocrinologist is the lead endocrinologist researcher on the project. And so I'm her patient, and she turned to me and said, I think you should do these. I was like, yeah, I think I should too. It's not because I work at JDRF. But so at the University of Virginia, where this work was being done, they now have a museum. And they have all of their early versions of artificial pancreas in that museum. And these laptops are in that museum. And to look at them and to look at all the original stuff, it looks incredibly antiquated already. And that's just 2008, right? So I came back again in 2010, and this is the last time I was here. I was talking to you guys about this. And this time it was eating, living, and exercising on artificial pancreas. So you'll see that there's still the, right here, the fanny pack is still there. But I'm no longer hardwired into the laptop computers. I'm now actually able to wear it in a little fanny pack, and it's got a little wireless router that's linking into the wireless network, and it's pushing the signal out from the pump and the sensor, and the laptops are somewhere else, right? So now for the first time, at least I could be ambulatory. I could get up and move around, and in this case, I could get on an exercise bike. This particular version of the trial was trying to make you go low, so they gave you lunch at 11 o'clock in the afternoon or morning, and it was a lettuce salad, and that's all it was. And then at 4 o'clock in the afternoon, they walked you down the hall, and they put you on your exercise bike, and they took you to 100% of capacity for 30 minutes, which is a sure recipe for making most type 1s go low, and it worked, right? When I was running the show, I got on that bike 4 minutes in, my endocrinologist walks in with a big thing of glucose tabs and just started feeding me glucose tabs, because I had just crashed. My numbers had just gone way down. When I got on there and the artificial pancreas had been running me, 5 minutes, 10 minutes, 15 minutes, 20 minutes, 25 minutes, I'm fine. I'm doing perfect, right? Low for the FDA was going from 70 to 69. So at the 26th minute, I hit 69. And so my endocrinologist said, here, you have to eat this glucose tab. And I'm sitting there going, no, I can do this. I can finish this. Because I'm all excited, right? I mean, it's so much better than I had done for myself, and I was trying to say, I can do this, and she's like, no, FDA protocol, we have to give you a rescue carb, you have to eat this, right? So I had to eat it, but that's the difference between artificial pancreas and no artificial pancreas. It's not perfect, it's just technology, it still will have some highs, it will still have some lows, but it's significantly better than we can do for ourselves, right? Very, very powerful. So now we jump forward 2 more years, and these clinical trials have been going on, of course, continuously. All this work has been going on around the globe. And now we hit just this time last year. In fact, right now this time last year. And then I went into the folks at UVA, and instead of going into the hospital, they just handed me this smartphone. So this is a Galaxy Samsung smartphone, right? How many people in this room have smartphones, right? These things we're all walking around with, right? This is a pocket computer. I talked about the man in the moon shot. There's 23 times more computing power in this smartphone than in all the computers that were used to send the first man to the moon in 1969. How about that? That's what happens when you hang out with researchers all the time, right? So we already know that these things are going to change our lives. Now I have a whole other way of demonstrating to you that these things are going to change our lives. So, and I almost turned off the system. So I showed up last November at the research site, and they said, here's your phone, you're good to go. No going into the hospital, right? I'm getting to now live out in the real world for 3 days and 2 nights, do whatever I wanted to do. So the very first thing I did was I went and found a Five Guys burger joint. Do you have a question?
Were in any of those three artificial pancreas trials, was this insulin that they were regulating, or was glucagon not being
So all of the trials that I've been in personally have been insulin only, right? But we do have trials currently underway in Oregon and in Boston that are using glucagon and insulin, right? So I'm going to get to that in a little bit, but that's the idea of we have something that can bring you up as well as bring you down, sort of brakes and accelerator on the car, right? So definitely looking at glucagon, but there's some real challenges to glucagon, but I'll get to that in just a second. So those trials are very cool, but they're just sort of further out than where I am right this minute. So, any questions? You guys have not been a big questions kind of a group here. They're all Lutherans. So down south, folks get way more emotional. So first thing I did, they handed me the phone, and I said, great, it's dinner time. And I went in, my philosophy was I wanted to give the system a test, right? I mean, we've got to figure out a way to do something that's really going to push to see how well the system can do. And so the nearest place that I could come up with was a Five Guys burger joint. So I went to a Five Guys, got a cheeseburger and some fries. I will be honest, I did not eat all the fries. I ate some of the fries. Have you ever seen how many fries they give you at a Five Guys? Crazy. So it's a Virginia-based company too. So anyway, I told it I only needed 1.9 units of insulin for my bolus for that meal. So next question, how many people think that's enough insulin for a Five Guys cheeseburger and fries, right? So I definitely underpitched that one to purposely see if the system could still do a good job of managing me. Now, I remember I was still a little bit involved here. This system is working to control terrain, just trying to keep me, say, below 200 and above 70. So it's trying to keep me within that broad range, and I'm still letting it know that I'm doing some big things, right? So an autopilot on the jet could fly me from Roanoke, Virginia to here, but to take off and land, it was really good that a pilot was there behind the yoke, helping to take the plane off and land it. Same idea with this artificial pancreas system. This is really useful if you're giving it good information. To get optimal performance, that's how the engineers would describe it, you need people to say, hey, I'm about to go exercise, and tell the system I'm going to exercise. And now it's giving me other messages. That's okay. Or if, by the way, this is in demonstration mode, this isn't live, and I'll be happy to pass it around and let folks look at it. Everything in it works. You can look at the blood trace and see insulin delivery and all those things. So afterwards, happy to let people look at this. But it is in demo mode, so people always worry that if they do something, they're going to zap me. And I trust all of you, but just not that much. So I told it how much I thought I needed. I ate that meal. My blood sugar started to go up very fast, and they started to get up towards 190, and they plateaued, and the system had been giving me extra insulin the whole time. Just kept looking and using the real-time data feed from the sensor, and kept giving me little micro boluses every 15 minutes. It's a whole new way of administering insulin, not something that we can do for ourselves because we can't stay awake making decisions every 15 minutes, but it can. I plateaued at about 190, 195, and then I came back down, and by bedtime, I was at 100. Right? And I hadn't had to do a thing, right? So how many times would you like to go out and eat one of those complex meals, Chinese or Thai or Mexican, Italian or just about any really good food, and you have to spend the next 4 hours sweating control, right? Did I do the right thing? Am I where I want to be? Am I going to be in a good place going to bed, or am I going to wake up in the middle of the night, right? All that went away. I didn't have to do all that. It all went away. Remember we were talking about less until none, less complexity, less difficulty, less burden? Right there, in my mind, a huge piece of things just walked away from me. I didn't have to own it so much. So, go ahead. Mm-hmm. I told it that's what I felt I needed, but it didn't give it all right away, right? The system is a smart system. And it said, okay, I take that under advisement. We'll see, right? And if you do, in fact, if I see your blood sugar start to look like there, because I've been drifting low. And from its perspective, I looked as though I was about to go low. So it was like, I'm not going to give this all to you right away. It did very shortly thereafter. It didn't take long for the blood sugars to start to stabilize and move up. And then it just started pouring on the insulin, right? So the second night I went out, and I had duck with raisin sauce. This is a fancier restaurant, and potatoes and cauliflower, and a hot fudge sundae. Same amount of insulin. I never went over 165. By bedtime, I was 100 again. And, oh yeah, by the way, each morning when I woke up, I was at 100. So 2 nights in a row, went to bed at 100, woke up at 100, perfect overnight control. So I always ask this question, how many people who have type 1 in this room right now, and even those who don't, would love to have perfect overnight control, right? I mean, I swear, if that's all it did, that would still be a huge leap forward. Because I don't know about all of you, but I get tired of waking up at 3 o'clock in the morning. My partner gets really tired of waking up at 3 o'clock in the morning because my sensors are going off at me and I'm having to stuff food into my face to get my blood sugars back up, right? That happens way too often for all of us. I travel a lot. I'm in hotel rooms alone. I would love to have my artificial pancreas turned on and it was taking care of me and preventing me from going low, right? And that's what it did. There's some amazing work being done in England, in Cambridge, this researcher, Roman Hovorka. He does work in teenagers, and a lot of them are in college, and you can see them going out, and his system turns on when they come back home. So as they walk into their dorm room, it picks up their sensor and their pump and takes over and starts managing them. So you can see, like on Thursday nights, Friday nights, Saturday nights, wild, crazy blood sugars until about 1 or 2 o'clock in the morning, and then they get back from having a good evening out. System takes over, brings them to 100, and keeps them there until they wake up about 1 o'clock the next afternoon. So just an amazing example. But that's just one place where immediately, from my perspective, I could see this huge, vast improvement over where I had been, right? So I already told you what it was like to not have to sweat the details of living with this and how great this overnight control was. There's some other really interesting attributes that are worth pointing out, artificial pancreas. And I keep wanting to emphasize, this is just one piece of JDRF's master portfolio. This is one small piece of what we're working on, right? So this picture right here, that laptop. So smartphones do another really neat thing, right? They report back up to the 3G, 4G network, which means that they can be monitored, right? So when those researchers handed me the phone and said, you're good to go, we've got you, they really meant it, because on their iPads, their iPhones, and their laptops, they had a URL open that had this exact same screen. That's me. Those 2 green lights are me being monitored remotely on the laptop computer. Everywhere I went, they could just look at a laptop and see, or anything that could pull up a browser and see where I was at. Now, it doesn't run the system. It was just monitoring it. But how many parents in this room would love to know where their kids were at 4 o'clock in the afternoon? And you know what I mean when I say where, where their blood sugars are, right? That's what this allows. Or another way of looking at this is, if your car can dial 911 when you've been in an accident, why can't your artificial pancreas, right? This has the ability, if I go badly low and I'm unresponsive, this system can send emergency responders to me. You can say, here's the GPS coordinates, this guy is unresponsive, here's all of his medical information, he's a type 1, you need to get there and do something. That's what starts to become possible when we have integration to cell phone. And I keep trying to turn this system off. In fact, I think I just did. Yep.
So, do you always have to tell it after what you are supposed to get in first? Or does it, I mean, like,
I told it before I ate, not after. But do I have to? It's a really interesting question. So to get the optimal performance, like I was describing earlier, it would be good if you did, right? We still see it, this is still an earlier stage. We see many stages, so the glucagon is a yet further stage. But this early stage, we see the user still needing to be somewhat involved, right? I'm about to go do a long run. I'm turning on the exercise module. Protect me and keep an eye on me because I'm now exercising. I'm about to eat a big meal. Pay attention. So there's a lot of different ways that these systems are put together. There's one group that literally has this as you just touch one of 3 buttons: high carb meal, medium carb meal, low carb meal. And it doesn't matter whether it's low, medium, or high in some objective sense. It's subjective. So what you might call a high carb meal, I might call a low carb meal, right? But the system is learning what you call low, what you call medium, and what you call high. And that's all you're needing to do to tune the system in. The engine how many engineers are in this room? Yay, I love engineers, my favorite people. So it's just a complex control system. So the engineers say, we need to know when there's perturbations to the system. That's the wonderful phrase they use, right? We just need to let the system know that something is coming that's about to change the performance of the system for a little bit, and it needs to pay extra attention. Now, ultimately where we want to go is the systems that get increasingly more sophisticated so that you don't need to be as involved in the decision making. So that's one way of answering that. Another way of answering it is we ate a snack purposefully and didn't tell the system anything, right? And it saw the blood sugar rise, and it tracked it, and it gave extra insulin and brought me back down to where I was supposed to be. If I had warned it that it was coming, it probably could have done a slightly better job of managing it, but it still managed it, right? So how many people have adolescents who, oh, I forgot, you know? How many of us adults will sometimes go, dang, I forgot to bolus, right? It happens, right? So this system is going to be able to help us with that scenario. It may not give us optimal performance, but going to this idea of glucagon, so glucagon really is attractive, right? This would have this ability to bring this up as well as push this down. Right now, the system can pull back on insulin, and it can suspend insulin to prevent us from drifting down or going badly low, and it does a good job at that. But obviously, it would be attractive, like, what if I do something stupid and try to force the system to give me extra insulin, even though it doesn't want to, and then I don't eat, or I go exercise, and I'm going badly low. If it could have glucagon to bring me back up, that'd be a good system. Only problem is, glucagon is not a stable molecule, right? How many people have ever had to use, I hope nobody has to raise their hand, the stupid rescue glucagon kit, right? That's got this giant instruction thing that you unfold that's got 16 crazy steps. At the moment, somebody's unconscious on the floor from a low blood sugar, and you're needing to sort of figure out how to mix up glucagon and give them a big shot. It's crazy, right? Because glucagon, by its very definition of what it does in the body, it's meant to last this very, very brief period of time. That molecule is unstable. It wants to break down and fall apart, right? Particularly in the presence of water. So that's why we don't have vials of glucagon sitting in our refrigerator for months at a time, and why there's no pumps that exist to give glucagon, because there is no stable soluble glucagon, right? So JDRF saw this as an obvious obstacle to getting to this really good control that we ultimately want to see these systems be able to do. So we launched the Stable Soluble Glucagon Initiative. We've now done 3 big awards on that, $2.2 million just in the last 6 months. And they are specifically targeting each is its own novel way of doing this, and I've seen the data from this and it looked really interesting, to create stable, soluble glucagon that would be in a vial that could be stable for long periods of time that you could use in a pump. So we are actually now actively translating that into first-time testing in humans. That work is now underway right now and should be the next 18 months or so. We'd like to see that happening. So that goes to your question about glucagon, but there's another wrinkle to the glucagon. Just again, to give you a sense of how much complexity there is in all of this, there is no pump that's capable of giving you both glucagon and insulin. There are no dual-chambered pumps on the market, right? Because we haven't had glucagon, so why would anybody have invented it? But now we're going to create glucagon that's available, so we need a pump that can do it. So JDRF launched a partnership with Tandem Diabetes, makes the T-Slim, it's a new pump, it's really cool. And they are working to develop the first ever dual-chambered pump that could give us both insulin and glucagon. The people that are in those trials right now are having to wear 2 pumps, and they have a nurse who has to be with them for 5 days continuously to check to make sure that the glucagon is still viable. And if it isn't, they replace it. So this is really complex, and yet we're still testing this already in human beings to show that the system can do these things. I know I'm going way too long. So all this making sense? I'm being told I'm going too long. So this is also a picture of me and Boris Kovachev. Boris is the guy at UVA who's the brilliant mathematician who developed the algorithm that makes this all work together. And this is, I call this the pancreas posse. That's my endocrinologist right there. And that's me. That's another patient. And two of the nurses, they went everywhere we went because basically they had nothing else to do, right? The system was running the show. They had to also, truthfully, they had to also be keeping an eye on us and making sure the systems were working right and validating all the data for the FDA. But they went, we said, we're going to go have lunch. Okay, we'll come with you, right? And it was actually kind of a lot of fun. For 3 days, I got to hang out and enjoy life. So that's what the artificial pancreas looks like. I would be happy to share this with people. Any other questions before I move on to the next concept? And then I'm going to wrap up pretty quickly.
Do the different brands of CGM have different technologies? Because I wouldn't trust the CGM.
Yeah. So which manufacturer do you use? Yeah. So the question is, do different types of CGM use different technology? So there are right now 2 different sensors on the market. Well, actually 3 now, so actually, but the Dexcom is one and Medtronic is another. And the Dexcom sensor is objectively, you can look at the data on this, is the one that's more accurate. I mean, you can see that the data scatter plots and see which ones are more accurate. The Dexcom sensors are way more accurate and they last for longer, but now Medtronic has just come out with their newest sensor that's a big jump forward, and it now lasts for 6 days and is significantly more accurate. But JDRF isn't satisfied with that, so we are pushing to get the next generation of sensors to come forward. So I've already played with the Gen 5. I'm wearing the Dexcom Gen 4, which just reports out to this little device that I have in my pocket. But the next generation sensor, the G5, reports into a smartphone, right? The integration into cell phone is a key component of what we want to see happen here. We're walking around with these pocket computers that have all these abilities to do these things, and that's where we want to see this stuff moving, and that's where Dexcom is going with their next sensor. Medtronic, so there's others working on this, but real quickly, there's another initiative that JDRF has launched, sort of the Next Gen Sensor Initiative. And so with Becton Dickinson, we've undertaken, well, Becton Dickinson, Dexcom, and Medtronic, we've undertaken the development of next generation sensors. I've worn some of those sensors. Again, another human guinea pig, another human clinical trial, active translational work. These were sensors that are about the size of a Tic Tac, and you put them on the body. You sort of just push on the sensor, the little fiber is glass fiber optic, very, very short. Can't even feel it when you push it on. I mean, literally, I couldn't feel it. Calibrated very shortly after it was put on, let's say 10 minutes, but until they commercialize it, we won't know exactly what it is. And that's it, one calibration, and the thing is good for the rest of the time you wear it, and it could be worn for 30 days, maybe, we'll see, right? That's what I got to see and play with, right? That's next generation sensor technology. I mean, think about it, the size of a Tic Tac, lasts for 30 days, calibrate it once. This is the kind of stuff that we see happening, that JDRF is driving to get to these better systems that go beyond what these are. But there was also a really interesting discussion that happened last April at the NIH, which was how much better do we need to get in order to see significant improvement over what the system is doing right now? And it was a really interesting discussion because the one thing that they all were concluding is we can get more accuracy here and that will be helpful, but we can have up to 40% variance between actual and what the sensor is reading and still see fine control from the system, right? The engineers will talk about this as noise and that you can factor into that. Our finger stick technology is not very accurate. So we're often locking in a 20% variance from our actual blood. So there's a lot of variables to all of this. These systems are built to deal with a lot of that variance and still perform well. Does that make sense? Jamie's going to shoot me, so I want to make sure I keep going. But any other questions? Yep.
Batteries, noise,
yep.
solar flares,
Yep.
whatever. Are they thinking about, what happens when my battery in my phone goes dead while I'm driving down the road or those types of things? Is it similar to your battery dying in your phone?
I've been waiting for you to ask that question. So thank you, right? So the absolute answer is yes, right? Technology fails. Technology is only as good as technology. This is not a full biological cure. This is just one of those things to less until none. This is improving the quality of our lives, reducing our burden, improving our control, right? But it's still technology, and technology fails. Our next big step for the artificial pancreas is right now the trial that you saw me in there lasted for 3 days, 2 nights. We've had a set of trials that have gone for 5 days at a time, right? Very, very short duration. Our next big step is 6 months. We want to put several hundred people onto this system for 6 months. And that's called pressure testing the system, right? You're going to have those people who like put the phone on top of the car and start driving down the road and realizing, oh crap, right? And then you don't know how to stop because it'll fly off the car, right? Or the 15-year-old who's out in the canoe and tips the canoe over and the whole thing goes to the bottom of the lake, right? So we have to figure out what all that looks like, and that's what's going to happen in the 6-month trial. Guess how much it's going to cost us to do the 6-month trial, right? Just the really important reminder of why it is that we do all that we do at JDRF to raise the money. $10 million to put that on several hundred people for 6 months and get all of that data. But that data is what's going to help to really pave the pathway to commercialization. It's going to say to industry, this is real, this works, this is when it works great, this is when it doesn't work so great, right, when the battery runs down. This is how you get the system to work when the battery does run down and you've managed to plug back in. Remember, it's going to be able to pull back up into the cloud. So it can take from the cloud and boot you right back up where you were, as long as it's not too long a period of time. Like lots of different things to be tested, and that's the kinds of stuff we'll be able to start looking at in a longer trial. So for the first time now, we're going from short duration to longer duration, small number of people to larger number of people, phase 2 kinds of trial versus phase 1 kind of trial. Does that make sense? So it's not perfect, but it's a big step up. So let me jump to the next slide, and then we'll try to wrap up. So encapsulation. Encapsulation is this idea of taking beta cells and putting them inside of a little capsule or a shield that's able to protect them from the immune system. When I was here a couple of years ago, you probably heard me talk about this as being the shark cage, maybe, right? So people always tend to remember that. So for me, the shark cage works because it's this idea. We want to take this diver, put him inside the cage, put the cage in the water. The great white shark can't get through and eat him, right? I want to do the same thing for beta cells. I want to take these little beta cells, put them inside the cage, put the cage inside the person, and the immune cells can't get through to eat the beta cells, right? Can protect the beta cells and allow them to function. And this is work that's conceptually has been around for a long time. JDRF has been pushing this in a lot of different ways. One of the best material science engineers in the world is at MIT. His name is Bob Langer. Basically, we went to him and said, why aren't you looking at this question? And he said, well, nobody's actually ever asked me to, but if you ask me to, I'll be glad to, right? So JDRF hired him, basically, and he's now got a whole bunch of research being done and seen some really interesting candidate materials being moved forward. But we've also are at a stage where we are actively moving this into human beings, right? So the work at Bob Langer's lab is still theoretical, being done with new biomaterials that could be used to encapsulate these devices. What you see there on the screen is from the company ViaCyte out in California. And this is a long-duration success story for JDRF. So this is a little device. It's called Encaptra, which I say sounds like a Marvel comic book hero. And so Encaptra is about the size of a Band-Aid. And you're going to be able to sort of open it up and put these cells inside, seal it back up, right? And then do a little outpatient surgery. Probably they're talking about opening up a little space on our love handles and inserting the little Band-Aid. It's really about as thick and as long as a Band-Aid. There's nothing, not much to it. And put it inside the body. And about 6 weeks later, the cells kind of spin up and start to sense the rise in glucose and release insulin in response, right? And the idea behind encapsulation technology is literally, if this works, it hides the cells from the immune system. And that means a lot of things become possible. It means that we can do, these devices can be implanted in you and we don't have to chronically suppress your immune system, which is one of the big challenges right now. We can do islet cell transplants, but you have to take immune suppressant drugs for a long time afterward. But if this device works properly, you won't have to do that. And then the other option is, because it's hiding it from the immune system, you can use other cell sources. You could use cells drawn from pigs. You could use cells drawn from progenitor cells, which are a kind of stem cell. And this device uses progenitor cells. This device, that's an actual photograph of the device against a quarter. This is going to be tested for the first time in human beings sometime in 2014. So sometime in the next several months, we will for the first time take a concept and translate it into active application in a human being. Does that make sense? It's very exciting. If this works the way we want it to, literally, you might have this little outpatient surgery. This capsule is put inside you. 6 weeks later, you walk away from insulin. You walk away from carb counting, finger stick testing. All that stuff goes away. And maybe it lasts for 2 years. Maybe it lasts for 3 years. Maybe it lasts for 18 months. I don't know. We'll have to see how long these last. Maybe they last longer. But the idea is then that for long periods of time, we wouldn't really need to do anything. This is a little kind of biomechanical artificial pancreas implanted inside our bodies. Is this a full cure? No. But is this less until none? Yeah. I mean, if I get to walk away from testing and I don't have to buy insulin anymore and I don't have to worry about going high or low, I just have to have this little device put into me every few years, that's a big less until none. And so this is what JDRF is doing step by step by step. I'm happy to answer any other questions, but I'm going to try to wrap up now. I'm not going to talk. I want to give you a sense that there's other things from our portfolio. There's smart insulin. I'm happy to talk about any of these afterwards if you guys want to stay and ask more questions. Smart insulin is one of these. This is the kind of idea of insulin that turns on when we need it and off when we don't. Very cool, but much further out kinds of work. Prevention. I talked earlier about the person who's 5 years away from being diagnosed. JDRF is doing a lot of work in the field of prevention and how we can prevent people from ever getting it. We never cured polio. We just prevented it, right? We all get vaccinated against it, and we never get it. The best way to be cured of a disease is never to get it. The day we wanted the cure was the day before I was diagnosed with type 1 diabetes, right? We all wanted the cure yesterday. The best ultimate solution is to come up with prevention strategies, and we'll get there. There's really interesting work going on there. So, and then restoration. This is what we might think of as the full biological cure. So this is stopping the immune attack and then causing the body to regrow its beta cells or replacing those beta cells. And we're working on that as well. I just wanted to give you a sense of the breadth of all that we're doing. This is another interesting piece that's kind of new for JDRF that you may never have seen before. This is something I have always advocated on behalf of, and our CEO is also a big believer of, which is Jeffrey Brewer, by the way, if you've never heard his name. So the idea is, if there's a big winter storm bearing down on Madison, you guys check the weather every couple hours to see what the latest forecast is. Oh, it's going to be 7 inches. No, wait, now they're saying 15 inches, right? I mean, you keep checking back because weather forecasts are dynamic and change. What this is an attempt by us for JDRF to do is to give you a sense of where some of these things that I've just been talking about lie in a framework of time, right? I have type 1 diabetes. I will never say to you, you'll have this in 5 years, because all of us living with this know how many times we've been told, don't worry, you're going to have this in 5 years, right? So it won't do that. But what I can tell you is some things are nearer to you and some things are further away from you. And this is just trying to give you a sense of where things are in a big framework, near term, midterm, long term. So artificial pancreas, this device right here, I'm wearing right this very minute all the devices that were necessary to make the system work. This is nearer term. This is going to reach us. It's still got to go through the big trials, which are only phase 2, so you still got phase 3s to go through. It's still a while away yet, but it's going to get to us. So this is a nearer term kind of project. Getting to soluble glucagon and better sensors that can do even better, that's maybe midterm, right? But they're going to happen. These things are already being tested in human beings. So JDRF is talking about these things in terms of time frames. If we see a big stumble, we'll change the forecast. And you guys need to come back and check the weather periodically with us to see, is this closer or has this been moved out further? If that device that I was showing you from ViaCyte fails dramatically, which it could do, we're going to push encapsulation out a little further. If it works, we may move it forward a little bit and pour a lot more resources in there, right? Constantly dynamic, changing environment, but we're trying to give you a sense of where things fall. Does that make sense? Yes.
And I really like the initiative to lessen the burden of diabetes. And I'm wondering if you need any near-term, mid-term, or long-term therapeutic improvements. JDRF is funding an institute to look at the impact of the psychological impact of diabetes and how to decrease that stress and how to help us cope with it while we're waiting for these things to happen. So tell me about the psychological work in terms of diabetes and
So the answer is yes, and yes, and yes, and yes. So the psychosocial burden of living with type 1 with a chronic disease, really tough, right? We never get a vacation. First thing we do in the morning, last thing we do before we go to bed, often what we do in the middle of the night, just never goes away, never stops. Every time we eat, we have to live with our disease. So JDRF actually convened a workshop of this last February of some of the best thought leaders in the world of the psychosocial to explore how we could make a significant, how we could do a relevant impact there, because it's a big, big space. So how do we find a piece of it where we felt like we could do something? So we're actually actively in the stage right now of building out a roadmap for things that we think we can do that will specifically address that, in addition to actual therapies that will obviously change the psychological component of living with this disease. So the answer is yes. I can't give you what that roadmap looks like because it's under active development right at this very moment. But we're definitely paying attention to it. Aaron Kowalski is the gentleman who runs the metabolic control area, if you've heard Aaron speak before. And this is one of his things that he believes in. A lot of, Nicole Johnson, who's former Miss America, who's on JDRF's international board, she has type 1 diabetes. This is one of her things. Trust me, there's a lot of people that want to see us figure out how to make a difference there, and we're trying to figure it out. We just want to make sure we spend the money well, where we know we can make a difference. So that's what we're trying to figure out. Yeah. Yeah. We think there's things we can do near term, but I can't tell you exactly what I think that roadmap looks like until we decide what it is. It's being actively worked on. The big challenge is, again, you're going to add another piece, and we've got all these other big funding things that need to move their way forward. So frankly, all of this speaks about to the bottom line, which is, and I always make this point, from Jamie, the ED, to my colleague Jen Lopez, who's here from Chicago, to me, to the CEO, to the top of research, to the person answering the phones in a chapter, we're all fundraisers, right? If we don't raise the money, none of this happens. JDRF doesn't have giant endowment that it draws against, like the University of Wisconsin. I worked for my alma mater, Virginia Tech, for many years. Love it, right? But we don't have an endowment like that. Every dollar we need every year, we have to raise. So there's a lot of pieces here to this puzzle. So let me just sort of wrap up then. And so this drives home that very next point where you were talking about the cash. And then I think I'm to the end. Oh, well, so then there's a final pyramid, right? So we talk about vision, plan, capabilities, and your support. Right? Your support is what makes it all possible. Our support, the money that we raise, is what makes all this possible. So thank you for your support, and I'm happy to continue asking questions. And if you want to come up and play with the artificial pancreas, more than happy to let you guys do that. Thanks for coming.